thanks for the opportunity, and I will try to fit this into 20-ish minutes so we have some time for discussion. As you said, it's a relevant topic to this pandemic, and I'm not going to talk too much about the pandemic because we all know plenty about that. But I will start by reviewing just basics of the viral morphology and replication, because I do think it's relevant for pathology, and also particularly when we get to ultrastructural identification of the virus. So the virus in itself is a single-stranded RNA virus that is enveloped, and by using the spike protein, which is part of the envelope, it attaches to ACE2 receptor on the cell surface, and then it fuses with the cell membrane, and the RNA just gets expelled into practically into the cytosol. So the enveloped form can be seen for a very brief point of time, and of course you can't really see an RNA floating in the cytosol. But that RNA will get translated and use the intracellular membrane complex to kind of like propagate and replicate itself. And at the final form, it will bud into a vacuole where you can actually see the enveloped form of the virus again. So that is very important, that enveloped form will not float freely in the cytosol of the cell that is infected. We are dealing with some of the variants of the virus, as you know, Delta and so on, but for the most part, the virus has been relatively stable. And I would say, our host reactions have been much more variable. So we go all the way from asymptomatic infections all the way to very actually dramatic and quick downhill clinical course with fatal outcomes in a short period of time. So there is that variability, and in between these extremes, you have probably majority of people having mild upper respiratory disease, sometimes going down all the way to the lung, where pneumocytes are very rich in ACE2 receptor and get hit hard by this infection. And you end up with the ARDS, and very frequently this starts the multi-organ involvement, which the kidney is obviously part of, and we will be focusing on that from here on. So acute kidney injury is relatively common, but when you look at the published literature in the past year and a half or so, you will see all sorts of numbers of the incidence varying from 0.5% to more than 80%. And it, of course, depends what population you're looking at. Are you actually talking about all infected people versus just patients that are hospitalized versus patients that are on the ventilator? And I'm showing here a study by Northwell, which is where I practice. So this study included about 5,500 patients, and of the hospitalized patients, the rate of acute kidney injury was about 37%. If you're looking at the population of patients that are on the mechanical ventilation, that number will be much, much higher. And what this graph here is showing is that in the middle is that usually the acute kidney injury will coincide with the time of placement on the mechanical ventilation. So where is this acute kidney injury really coming from? So that has been a lot of debate, and I would say, I think pretty much we all now agree that most of the injury is really coming from the cytokine release and indirect causes where you have hemodynamic instability and circulatory factors that may really be responsible for the acute tubular injury. Sometimes this may come with rhabdomyolysis, There are also interferences with other systems like complement coagulation and so on, and we'll talk a little bit about that. Obviously, in some patients, you may have a factor of hypovolemia or even medication-induced injury. But this question of direct viral infection, I think, has been the most controversial in the past year. So we will address that a little bit later on in this presentation. So the common histopathologic findings that have been reported in all autopsy series, but also in biopsy series, include acute tubular injury, which is non-inflammatory without really significant cytopathic effect that we would attribute to the viral infection. And as I said, hemodynamic and other indirect factors are more likely to be responsible for the clinical presentation behind it. But we've seen also significant endothelial cell injury, even with TMA. Collapsing glomerulopathy has been described as the most common glomerular lesion in COVID-19, and we'll talk about that a little bit as well. But there are other presentations which I will briefly mention at the end. And I will start by mentioning the first report, which came in February, March last year from Wuhan, China, which described 26 patients that underwent autopsies, post-mortem evaluation of the kidney tissue. And I will describe their kidney pathology on histology, on light microscopy in the next few slides, but they also describe these viral-like particles as well as positive findings by immunofluorescence. And we'll talk about the viral detection at the end, but I first want to go over the just simple histology. So what they were describing, and I'm showing only some of their images, is really just like flattening of the epithelium, distension of the lumens, some cellular debris in some of the lumens. You may see also some pigmented casts in rare instances, but very non-inflammatory. And some patients also had segmental fibrin thrombi in glomeruli. Some had pre-existing ischemic changes like hypoperfusion and so on. So very non-inflammatory. The other important study came from our colleagues at Columbia. This was the largest autopsy study with 42 patients included, and more than 90% of them presented with AKI. And that's what I was saying at the beginning, like you have to know your numbers. So these patients predominantly were, with severe COVID, they were on mechanical ventilation, and many of them had very profound AKI. However, on histology, they showed just mild acute tubular injury, typically less severe than you would predict based on the level of acute renal failure they had. And I'll show again just some of their images. They categorize their patients into groups depending on the level of AKI clinically, and they found different levels of ATN practically, or acute tubular injury, on histology. So they also showed that some of their patients, about 15%, had these microthrombi in glomeruli and some vessels. So in about 15% of patients, they also showed that some patients had this pre-existing injury like early diabetes or vascular sclerosis. Another study also from New York showed that these thrombotic changes were actually common. And this study included complete autopsy evaluation in 7 patients. So multiple organs involved by thrombotic changes. And here you have kidney with these peritubular capillary fibrin thrombi. So this is a little bit of an outlier because they show that all of their 7 patients had that. But I think in other autopsy series, it was very common to find some percentage of this finding. So where is that coming from? Knowing that ACE2 is also present on endothelial cell surface, we postulated that maybe direct infection is responsible for endothelial cell injury. However, these patients are rarely found to be viremic. So other possible explanations included indirect effects through activation of macrophages that also can be infected themselves, and then they can trigger this cytokine release and cytokine storm that can interfere with various functions of the endothelium and lead to prothrombotic changes. Also, as the ACE2 is part of the picture and it gets downregulated through the infection, obviously you may change certain signaling that may lead to prothrombotic events. And also, alternative pathway dysregulation in COVID-19 has been studied, and we at least had one patient in which we think that this was a major event and cause of her severe thrombotic microangiopathy with cortical necrosis in the kidney that led to her death within few weeks of initial infection. So these are all very important aspects, and endothelial cell damage can be actually present in some of the patients that have been reported with COVID-19 related kidney disease. In this particular table, which I modified from our review that we published early this year, what I'm trying to actually say, and I know this looks a little bit busy, but what this is really you have 7 autopsy studies, 1 from China that I already mentioned, 3 from the States, 3 from Europe. And I think we were all seeing very similar things. Most of these patients were with, clinically significant acute kidney injury. Very often we were seeing acute tubular injury or ATN on histology. And we were seeing similarities, but where we differed was in a way that we handled viral detection. And I think some people were using different techniques, immunofluorescence, in situ hybridization, immunohistochemistry. Even within the same technique, different antibodies were used, different protocols, and also different threshold for calling something, let's say, weakly positive versus negative, I think differed. And therefore, we had a lot of controversies related to the presence of direct viral infection in the kidney in the past year. I will start by showing our study that we published at our institution. So 12 patients, these are postmortem kidney biopsies, so not full autopsies, not full sections, just needle core biopsy after these patients died of severe COVID. 11 were on the ventilator. They all showed ATN at various stages, and we tested all of them by immunohistochemistry, and they were negative. This is a positive control on the bottom here. And we did in situ hybridization in 4 of these cases, and all of this was negative. We also did electron-microscopy on all 12, and this was also, we interpreted that as negative. So going back to the very introduction, when I said that you are not supposed to see a freely floating enveloped virus within the cytosol, this cannot be, therefore, the virus. So these are what we call clathrin-coated vesicles, and these are microvesicular bodies that can also mimic virus. So many of these were interpreted or misinterpreted as viral particles, but I think really the knowledge of replication and how this virus actually goes into the cell and what it does, I think is really very important. I found this publication very helpful. So Sarah Miller from Duke was the senior author on this paper, and she actually described in detail how this should look like. So these budding viral particles should actually have this envelope, but the spikes are not very well visualized by regular routine and transmission electron microscopy. You should also see this kind of like dot in the middle, which is nucleocapsid. And when you see these enveloped forms, they should be within the vesicle. or outside the cell. And this is that remodeling of the membranes within the cytoplasm that you may sometimes see as a consequence of viral replication. So I wish this was published earlier because prior to this, we had a number of publications saying, oh, these are viral particles. Then a number of other publications saying, oh, these are not viral particles. So that controversy was there. But it's really difficult by electron microscopy to kind of like pin the virus because you're dependent really on shape and size only. So other techniques were immunofluorescence, and even in the first published series from China, they actually said that 3 out of 6 cases that were tested by immunofluorescence were positive, and these are their images. Then came out the paper from New England Journal saying that in situ hybridization was positive in glomerular cells, in podocytes. But you kind of like can't tell how many of these cells and how often are you supposed to see, because remember, we did the same study, we did the same technique, and all of our cases were negative. So I think what I found really helpful was when Dr. Wines, also from Brigham and Women's, and now a colleague of Dr. Renke, when she shared these images with us, practically the story is they had about 30 autopsies, so about 60 kidneys. They did immunohistochemistry on all of them. And the only little focus that was ever positive was this tiny thing that you see here. And as you can see, like this is very low power, but if you did a core biopsy just next to it, you would have missed this little area that was repeatedly positive. So yes, you can have direct infection, and the presence of the virus can be seen, but this was not even your typical patient. As far as I remember, this was a patient who was immunosuppressed. They had bone marrow transplant in the past, so it was not like a healthy person who had severe COVID and passed away. No, this was an atypical kind of situation. So under certain circumstances, you can see this, but to what extent this actually interferes with intracellular functions and leads to AKI, I think it's very debatable, and I personally don't think it's significant. But at the same time, I do see that this can be a factor in certain circumstances. So I'll leave it to that and move on to another interesting problem that we had, which is in terms of the glomerular involvement and glomerular disease in COVID-19. We have been seeing mostly collapsing glomerulopathy, or actually that was definitely the most common lesion, particularly in Black patients with 2 APOL1 high-risk variants. Let me see, I'm trying to move my slides and they're not moving. Okay, here. The first report actually came from Chris Larson, and this was a 44-year-old African woman with, I don't even think she had that severe COVID-19, but she did have AKI and nephrotic range proteinuria. And after that report came, in my count, over 50 other cases, whether it was in biopsy series or case reports, mostly in Black race, and very commonly with acute kidney injury. So just to show one of these studies, just to paint the picture how these patients present. In this particular case series of 6 African-American patients, mean serum creatinine was 6.5, and the proteinuria was over 11 grams. All of them had high-risk APOL1 genotype. No viral particles were seen on EM, and they had negative in situ hybridization on all 6 patients. So that's your typical collapse in COVID-19. Other presentations, including myoglobin cast nephropathy, have been reported by Columbia Group, but also by us. oxalate nephropathy in patients with excessive vitamin C. We have this report from Fontana from Italy. Vasculitides have been reported with, interesting actually points whether anti-GBM becomes more likely after the ARDS and so on. That was a debate in some of the instances. But any other practically glomerular disease has been reported. And now you can actually argue that some of them are coincidental, others may be worsened or triggered by COVID-19, but here they are. They're all here listed. And I'm not going to go through these all of these examples. I'll just mention that in case of membranous nephropathy, that both PLA2R positive and negative forms have been described. I'm also going to mention that with COVID-19, we're also seeing reports of glomerular disease, particularly minimal change disease, but ANCA vasculitis has been described in association with vaccine. So we are not done with, learning about kidney pathology in COVID-19. But I will just summarize. This is my last slide, and just to tell you what I have told you already, which is that the most common finding is acute tubular injury. TMAs and endothelial cell injury, as well as collapsing glomerulopathy, are also important pathologies. Sometimes with ATN, you may see myoglobin cast nephropathy. Many other glomerular diseases have been described, and also these medication-related pathologies, such as oxalate nephropathy with vitamin C, or AIN with different medications, have all been described. So I'll leave it to that. I will thank you